Okay, Pharm Scholars, this is the last chapter that is needed for your quiz on Wednesday. We are getting ready to jump into chapter 19. This chapter is on drugs used for pain management. And please, again, remember to go over the objectives. And I'm going to jump right in on slide 4. That's just after the objectives, I believe. Yep. So we're going to talk about pain and the medications used to treat pain. So again, I'm on slide 4 if you're following along. So pain for a patient or anyone is an unpleasant sensation that is part of a larger situation, is a pain experience. Let me say it again. An unpleasant sensation that is part of a larger situation is a pain experience. So, when we're talking about pain, 3 things apply: pain perception, pain threshold, and pain tolerance. So, with those 3 components, pain perception is what the patient perceives their pain to be. Pain threshold is the highest amount of pain that they can tolerate, or it's like where the pain is first perceived. Threshold is where the pain is first perceived. So let's say the pain started in their shoulder, but now their whole arm is hurting. Well, threshold is where the pain was first started or perceived, okay? I apologize. Now, pain tolerance is the person's ability of how much of that pain they can endure. Or pain endurance. Pain it can be described in more ways than one. Okay, so we can have acute pain. You all know what acute is. It's a short term, right? So it can be like short-term pain because it was like a low minor injury. Pain can also be what we call chronic pain. It tends to have a slower onset, and it has lasted longer than 3 months beyond the healing process. So say a patient had an injury. Let's talk about the shoulder since that's where we at. Had a shoulder injury and continues to have pain, discomfort in that shoulder, and it's now been past 3 months. The healing process of this with an injury, that patient has now moved from acute to chronic pain, okay? Pain is highly subjective, and it can be influenced by behavior, psychologic, sensory, emotional, and cultural factors. So let me say it again. Pain is what the patient say it is to them. Pain is subjective, and it can be influenced by behavioral, psychologic, sensory, emotional, and cultural factors. Chronic pain is subdivided into malignant, which can be pain that's cancerous, and non-malignant, okay? I'm moving on to slide number 5, and how pain is classified. This is how pain is classified, okay? So, pain is classified by its pathophysiology, which means where is it stemming from, okay? Pain is classified by pathophysiology, which means the pain is classified by where it starts from or where it's coming from, all right? So your nociceptive pain is what we call a dull, achy type of pain, okay? I would become familiar with the classifications of how pain is classified. I would start that if I was you. Pain and pain medications is huge. Another huge, heavy, kind of a heavy weighter. So, okay. Your somatic, you can have somatic pain. Your somatic pain originates from your skin, your bones, and your muscles. Okay, let me say it again. Your somatic pain stems from skin, bones, muscles. Then you can have what we call visceral pain. Visceral pain originates from the abdominal and the thoracic areas. Abdominal, thoracic is in the same area. Remember what I said? We need to start stretching a little bit and start connecting the dots. So, visceral is your major organ compartment. So visceral pain will stem from your vital organs, primarily your abdomen and your thoracic. Okay? Your neuropathic pain results from nerve injury. So I got in a car accident. My leg ain't quite the same. I constantly have numbness and tingling. Numbness and tingling comes from nerve stuff. So it results from a nerve injury. And most people will say it feels like a stabbing or burning discomfort. Okay? Then we have what we call idiopathic pain. It's non-specific and it's of unknown origin. So idiopathic means, okay, they're having it. We don't know where it's coming from. Okay? It's an unknown origin. So, if a patient is complaining of menstrual cramps that are getting worse and worse, menstrual cramps is in this area here. So your vital organs includes your uterus, all this stuff through here, right? That's what we would call a visceral pain. So let's say your patient said, I had a virus a couple months ago, but now everything just hurts. Okay, they had an infection a month ago. Now everything just hurts and they don't know why. That would be considered an idiopathic pain. If I fell asleep in the back of my brother's car and now my shoulder is killing me, that because it stems from the skin, bones, or muscle would be what we call a somatic pain. And just say a patient is complaining of stabbing, shooting pain that runs down my left leg. Okay, remember neurologic pain, they have a stabbing and burning pain. So if the patient is complaining of shooting pain that runs down their leg and it feels like a stabbing discomfort, that's a neuropathic pain. Okay, neural nerves. This component of this slide is in figure 19.1 and is in the textbook on page 302. Okay? I am moving on to slide number 6. So now we talked about the pain. Now, how are we going to manage it for the patient, right? So analgesics relieve pain. Analgesics relieve pain. They can be classified according to neurologic mechanisms. So, what I mean by that is, we have opiate agonists. Those are usually prescribed for severe acute pain. We have opiate partial agonists for unrelieved or moderate acute pain. A patient may be on an opiate antagonist. These reverse adverse effects of opiate agonists. Okay? I know, just hang with me. Salicylates might be used for mild acute pain. And it's on your slide, so just go back and get familiar with it. And then we may see a patient that's on non-steroidal anti-inflammatory drugs. You're going to hear these called your NSAIDs. These are often given or prescribed or suggested for mild acute pain. So, I got a little dull egg in my side. I bumped it, so I want that pain to go away. You may take an NSAID. NSAIDs is like your Advil, ibuprofen, along those lines, okay? Then there's a miscellaneous category. So, let's talk about analgesics, okay? Because analgesics relieve pain without producing loss of consciousness or reflex activity. So what that's saying is the analgesics will help take care of the pain, but the patient doesn't lose consciousness, or they don't get like drowned into such a state where they lose their reflex activity, okay? Pain management must be potent enough to afford maximum relief of pain. What that's basically saying is pain management must be efficient or working enough to minimize the pain, okay? Not these are typically not dependence upon them, and they have minimal adverse effects. We're talking analgesics. They typically are not, people don't get depending on them, and they have minimal adverse effects. So we're still talking about pain management. I'm moving to slide 7. Slide 7. So pain management. When injury occurs, the body releases chemicals that contribute to pain. So when we talk about chemicals, the chemicals we just talked about in the last module were neurotransmitters. So when injury occurs, the body releases chemicals that contribute to pain. Drugs used to block these chemicals include antihistamines, your prostaglandin inhibitors, which are your NSAIDs, your non-steroidal anti-inflammatory drugs, and antidepressants. Those, you see, we just got done having a test on your TCAs and your SSRIs, your selective serotonin reuptake inhibitors, and also substance P antagonists. Okay? We are moving on to slide number 8, and we are still talking about pain management here. So we're trying to manage that pain for the patient. So, the Joint Commission current standards for pain management therapy are: 1. Relief of pain, intensity, and duration of pain. 2. Prevention of conversion of persistent pain to chronic pain. So what they're saying is we're trying to keep it from moving from a persistent pain to a chronic pain. We still talking about the Joint Commission and the standards set forward for pain management therapy, right? Number 3, prevention of suffering and disability associated with pain. We don't want our patients to suffer or become debilitated by the pain that they're having. That's what that's saying. Prevention of psychological and socioeconomic consequences associated with inadequate pain management. Number 5, control of adverse effects associated with pain management. Number 6, optimization of the ability to perform activities of daily living. So we want to make sure that our patients can function on a daily basis. You can refer to figure 19.2, see the World Health Organization Plan Relief Ladder, and that is page 303, I do believe, last I looked. We are going to move to slide number 9, and now we're going to talk about pain assessment. So now when you're dealing with your patients and they're in pain and you're meeting them, they're getting, interacting for the first time, you're probably going to need an assessment of where they are with their pain, okay? So, slide number 9, we're talking about pain assessment. So, this pain assessment or pain is considered, assessment is considered the 5th vital sign. Is to be assessed with vital signs and before and after interventions. So they're saying it needs to be assessed before and after any kind of drug therapy starts and after it's started. So you want to assess your patient before, if that's the case, before your medication is started, and you want to assess your patient during the whole process because you need to know if it's working, right? Do the meds need to be changed? Do the doses need to be upped? Is it too much? Do they need to be decreased? Those are assessments. But one of the things you're going to get real familiar with is the pain assessment tools. So one of the pain assessment tools, there are various tools that can also be used for nonverbal patients, infants, and children. And this is the smiley face scale that you often see. The scale is from 0 to 10, with 0 being no pain and 10 being the most intense pain, okay? And you can see this. This is called Wong-Baker Faces. It's a pain rating scale, and I do believe it's in figure 19.3, page 304 of your text. So get familiar with that pain assessment scale, okay? I'm moving on. We're still talking about pain assessments. I'm moving on to slide 10. So, pain assessments. Again, what is the patient's perception of their pain? Believe the pain experience they say they are having. Because if you are on the other side of the table and you're trying to get somebody to understand how much pain you're in, you want them to believe you. So believe the pain experience your patient tells you they are having. Ask the patient, when did it start? Where did the pain start at? What's the depth or quality, duration, severity of the pain? And is there any nonverbal behavior you see with your patient? A nonverbal patient meaning they may grimace because they can't take it. Is they like clenching their side? Look for those nonverbals as well and incorporate those into your documentation notes. Please refer to figure 19.4 to see the McGill pain questionnaire. Is a pain questionnaire. I think it's on page 306. And then you can see different various pain rating scales, I think on page 307. All right? Get familiar with those. Because no matter really where you work, at some point you're going to have patients complaining of pain. That's why I said pain is kind of a heavy hitter, because it's one of those things you're going to see more common maybe than some other disorders or disease processes. Okay? So I'm going to move on to slide 11. We're still talking about assessment. As you're talking with your patient, what is your history with your pain experience? What is the nonverbal observations you're seeing? What have they tried for pain relief, if anything? What physical data is going on? Is it interrupting like their activities of daily living? They're limping, what is the physical piece of that's going on? Is how that pain is interrupting with their physical ability. And what is their behavior response? Because really, when people are in pain and hurting, sometimes if they've been hurting for a long time, it's nice to be nice to people when you're hurting. So what is their behavior? Make sure you're capturing all this in your documentation when you're doing your assessment. Now we want to implement related to pain. So I'm moving on to slide number 12. So nursing implications. So if you're dealing with your patient, a big thing is their comfort measure. Let's get our patients comfortable, okay? Can they exercise and move around? Do they have enough? Is the pain enough, so much that they can't even walk to the restroom in the hospital and things like that? So what is their physical activity level? What can they endure? What kind of non-pharmacological approaches have taken place? Oh, the shoulder has been bothering me. I've been using the heating pad on it for the last 2 weeks. Or my knee was swollen so bad I've iced it off and on for the last couple of days. Find out what they've done that's not related to medications and incorporate that in your assessment and your documentation notes. Have they tried any over-the-counters? I've tried extra strength Tylenol. I've tried Motrin. I tried Advil. To find out if they've tried anything. Did they feel those medications help? At least minimize the discomfort. If they're already on a pain medication, do they feel like their pain is a prescription medication? Do they feel like their pain is being controlled? What is their nutritional status? And so on and so forth. So now I'm getting ready to move on to slide number 13. So those are kind of what you're going to implement. So on slide number 13, we're now going to talk about non-pharmacologic approaches. So these are things that we're going to do that are not medication related, right? Non-pharmacologic strategies enhance effects of medications. So what about back rubs and repositioning the patient with pillows or whatever heat and cold applications? We just talked about that a little bit the slide before. Maybe some relaxation techniques. Diversional activities, something they like. If they like to watch, Family Feud or play cards, or if they color, if we can divert them a little bit, sometimes it takes that thought process away from the pain that they're having a little bit. Decrease the environment stimulation. If the environment is overstimulated, too loud, too light, too bright, is busy, make sure, try to decrease the environmental stimulation. Visualization. Okay, let's relax and go into our R&R. Let's visualize you laying on the beach on the sun and you can feel the warm water hitting your face and things like that. Biofeedback, meditation, and TENS unit. I don't know, biofeedback is a therapeutic technique that uses electronic devices to provide real-time information about physiological processes such as the heart rate, muscle tension, skin temperature, stuff like that. This information helps individuals gain awareness of their bodily responses and learn how to control them. That's biofeedback. And if you want to elaborate on that, just look up biofeedback, okay? TENS unit is an electrical nerve stimulation. They call it transcutaneous electrical nerve stimulation. This is where they hook up like little electrodes to whatever area that is, and they get little shocks to kind of help with nerve stimulation, okay? Or nerve pain disorders, stuff like that. So we are on slide 14. So here we are. Medications related to pain. So encourage your patients to request pain medication before the pain escalates. Because by the time the pain escalates, they're going to feel like they need that much more pain medication to get their pain back under control. Once we get a patient's pain managed and stabilized, it's important. This is patient education. Tell your patient, as soon as you feel the discomfort coming, ask for your pain medication, because then we keep the pain there and then we don't put our patient through this yo-yo effect. You know, my pain is so out of control. Then we get the pain under control and then they don't ask for the pain man. Now their pain is out of control when we can keep them more stabilized and keep them more comfortable, okay? Identify when the last dose of pain medication was administered. Those should be in your MARS, whether on paper, whether electronic. That's why it's huge to make sure you document as soon as your patients take their medications. Because if you miss a slot and on a PRN and the nurse come in and they think they didn't have it, they could give that patient another dose and it's not going to be a pretty picture, okay? Pain scale assessments are used with pain relief range orders. So the doctor may be like, make sure we're documenting what their pain scale is prior to administering these medications. That's what that bullet point is saying. Pain scale assessments are used with pain relief range orders. So if the doctor says the patient has a pain relief range, then you'll probably be doing a pain assessment like the Happy Faces or some kind of pain assessment tool to find out where your patient's pain level is at, okay? Moving on to PCAs, that is on slide number 15. So we're talking about medications used to manage pain. Medications used to manage pain. Slide 15. So, some of you may or may not have heard about this one. This is a patient control analgesia. You'll hear it called a PCA pump. There are pumps where the medication is already accessible for the patient, and they can push a button when they feel like they need the medication. There's some things going on with the PCA pump, but I'm going to read through the power slides first and see if we cover it before I make mention. Again, patient-controlled analgesia. Analgesia, that's a PCA, and you'll often hear it called a PCA pump, okay? It is a syringe pump, contains an opiate agonist, so usually morphine or some high level of pain medication, connected to an IV pump and an IV catheter. So this is something they're getting in the peripheral IV, right? The patient self-administers small doses of the analgesic when they feel that they need it. So they have, again, a little button. So when they feel they need it, they can push the button. Pumps limit the amount and frequency of the dose. So what that means is, if the patient pushes the button now and in 20 minutes they feel like their pain is not controlled and they push the button again, and they may not get any medication because it depends on how the dosages are set in the machine. So they can push away, but the machine is set to deliver those doses based on how they're calculated into the pump, okay? The pump limits the amount and frequency of the dose. Provide patient family teaching on the pump. And you can let them know in patient education. You know, if your pain is coming on a little sooner than your next dose is due, even though you push, you may or may not get a dose depending on where you are on that dose cycle, right? Record the amount used and the degree of pain relief. So these pumps keep track of how often the patient is pushing. And then chiming in if your patient has a pump and see, and then now they got access to the button. So now you need to come back and ask them how is their pain doing, because unless you know what the dosage is and how they're released to set at, and you probably could if you once you learn how to maneuver through the pump mechanisms, you can kind of see when they had a dose last and things like that. So do you feel your pain is being relieved and things like that? Okay, so that's the PCA pump. Now I'm going to move on to slide 16, your patient education. Again, teach the patient and the family and the significant others the benefits of adequate pain control. Even if the patient is taking pain medications at home, if they feel, if it's due to an injury and they feel they need them, it's better to stay on top of the pain instead of letting the pain get out of control and trying to get the pain managed back. So it's teach them how the benefits of adequate pain control. Foster health maintenance. You know, just make sure your health maintenance and the regime you're supposed to be following is good. And patient self-assessment. Again, have your patient assess with how they feel that. Oh, I'm sorry, y'all. Where they are in their pain process or management. Okay. Chapter 7, slide 17 is a question. You can answer that and we can talk about that in class if you like. And then I'm going to move on to slide number 18. And now we're getting ready to talk about pain meds in the drug class. And they're called opiate agonists. Opiate agonists, okay? So, the action of these meds act on the same sites in the brain as morphine to stimulate an analgesic effect, which blocks the pain sensation, okay? Let me say it again. So, the action of these opiate agonists is that they act on the same sites in the brain as morphine would, and as morphine to stimulate analgesic effect. So if you're stimulating an analgesic effect and analgesics is for pain, then our pain is going to be managed, right? They block the pain sensation. They are used to relieve acute or chronic, moderate or severe pain. They can be used preoperatively, so before surgery, or to supplement anesthesia if someone is having surgery, okay? Prolonged use can produce drug tolerance or addiction, may develop after 3 to 6 weeks of use. So you got to educate your patients, you know, if the doctor's ordering these meds for a certain period of time, if they can maybe try to find some non-pharmacological methods of helping continue to get them on their path of healing, so that they're not calling back and asking for these meds, because it only takes 3 to 6 weeks of use for a patient to drug tolerance. As their body get tolerant to it, now they need more to do the same thing, or they get addicted. So now they're drug seeking because they're addicted to the medication. Okay. So those are your opiate agonists. So now we're going to talk about the drugs in that class. So we're on slide number 19. So these are going to be your morphine-like derivatives or drugs that act similar to morphine, codeine, hydrocodone, oxycodone, meperidine-like derivatives, methadone-like derivatives, and other opiate agonists. So our common adverse effects we're going to see with these is lightheadedness, dizziness, sedation, sweating, confusion, disorientation, static hypotension, nausea, vomiting, and constipation. Almost all your analgesics has the ability to cause constipation. So plus your education, make sure you're getting fiber in your diet, okay? Because almost all analgesics will cause constipation. It's binding. Our serious adverse effects is respiratory depression, naturally. So respiratory depression, urinary retention, excessive use or abuse can happen, and increased effect with the central nervous system depressants. So if a patient is taking a CNS depression, these are going to enhance that. If your CNS is already depressed and you take an opiate agonist, it's going to be depressed even more. This is how people die, because their heart slowed down so much it stops. Okay? For specific, I'm sorry, y'all, just got to readjust. For specific drugs, see table 19.1, and that's on page 311. Now, drug interactions with our opiate agonists are tranquilizers, tricyclic antidepressants, antihistamines, and alcohol. Again, drug interactions with opiate agonists is tranquilizers, our tricyclic antidepressants, antihistamines, and alcohol use. Okay? So let's move on to slide 20. So there's monitoring parameters with opiate agonists. There's monitoring. You're going to monitor the parameters related to opiate agonists. Here we go. Sorry. So we want to do a pre-medication assessment and planning. So appropriate pain assessments is necessary. So you got to use those wonderful pain assessing tools and resources available to you to get your baseline prior to medication. Our therapeutic goal with our opiate agonist is we want our pain at rest to be less than 3 on the pain scale. So if a patient is taking an opiate agonist, one of the therapeutic goals is to have the patient's pain at 3 or less on the pain scale. Pain with movement less than 5 on the pain scale. So if they got to get up to go to the restroom, oh yeah, my pain is a 4. I'm at a 4. That's a therapeutic goal with opiate agonist, okay? And the patient needs to be able to have at least 6 hours of sleep without interruption by pain. They need to be able to work a hobby for at least 1 hour. Observe the vital signs and mental status changes, especially the respiratory rate. These are respiratory depressants, okay? Hold medication if respirations are below 12 minutes for an adult, 12 beats per minute. Consult with the healthcare provider. If your patient is on an opiate agonist and their respirations are below 12, hold that medication and get in contact with the healthcare provider. When you're doing your pain assessment, that includes the onset, location, the depth, the quality, duration, severity of the pain, using some type of scoring system. Pain scales use a rating of 0 to 10, 10 being the worst and 0 being none. Find out where your patient is on that scale. If a patient is getting a medication, if it's routine, that's one thing. If it's PRN and you have a range of what you can give, always administer the smallest possible dose that allows for pain relief and figure out if that's working. So what I mean by that, so the doctor ordered that they can have, let's say, Tylenol with codeine or oxycodone or something like that, because that's one of the opiate agonists, right? They can have 1 to 2 tablets every 6 to 8 hours as needed for pain, right? So if they can have 1 or 2, and your patient is always start with 1 pill and go back and determine the effectiveness of that 1 pill. Reassess your patient. Where's your pain level at right now? If the patient is saying that pill is not controlling or managing their pain, then the next time they can have that PRN pain medicine, give them the 2 tablets and see how they do. Okay, so you always want to start with the possible dose that is allowed, and then move your way up. Okay, let's move on to slide 21. 21 is a question. You are welcome to answer that question, and we can talk about it in the class. I will bring these with me in case there's any, if y'all want to do that. And then now I'm going to move on to slide 22. Okay, so now, and y'all hang in there. I just need y'all to divide these out. So now for pain, we're going to talk about opiate partial agonists, right? So they're effective analgesic without prior administration of opiate agonists. Pharmacologic action depends on whether an opiate has been previously administered. Subject to ceiling effect. We'll talk about the ceiling effect. So your opiate partial agonists are subject to a ceiling effect. Prolonged use leads to tolerance. So that now the patient built up a tolerance. So now they're going to get on the phone calling the doctor saying, that ain't working for me anymore. So when you got a tolerance, either the doctor needs to up the dosage or they need to up the amount of times you're taking it in a day, right? It's often used in short-term relief up to like 3 weeks of moderate to severe pain associated with cancer, burns, renal colic, preoperative analgesia, and obstetric and surgical analgesia. In the presence of opiate dependence, opiate partial antagonists will induce withdrawal symptoms. So, what I just said is in the presence of opiate dependence. So, if a patient is dependent upon an opiate partial agonist will induce withdrawal symptoms. So when the patient ain't getting it or it's not being prescribed, they're going to have withdrawal symptoms, okay? And please see table 19.2 on page 317 of your textbook. Okay, so we're still talking about opiate partial agonists, and I'm moving on to slide 23. So, on this slide, you see the drugs that's listed there. One of the common ones that I'm familiar with is Stadol. Common adverse effects is calmness, dizziness, sedation, sweating, nausea, vomiting, dry mouth, constipation. Again, the common adverse you'll see with these opiate partial agonists are a calming effect, dizziness, sedation, sweating, nausea, vomiting, dry mouth, constipation. Serious adverse effects is confusion, disorientation, hallucinations, respiratory depression. Less than 12, call the doctor. Remember, respiratory depression, excessive use or abuse of these particular medications. Buprenorphine is also used to treat. So that's your Buprenex, Subutex. That's the first one listed on this slide. They're also used to treat addictions to heroin, painkillers, and opiate products. So check for prior use of opiate agonists when you're doing your assessment with your patients, okay? So now we're going to move on to slide 24. These are, okay, so now we're switching gears a little bit. So now we're going to talk about our opiate antagonists, okay? So if opiate agonists help with the pain, an antagonist is going to do the opposite of that. This is where you get into your naloxone or Narcan, because it reverses the effect of opioid overdose, right? So here we go. So your opiate antagonist is Narcan and Riva or Revia. It reverses respiratory depression because remember, that's why they say if they're taking these agonists with other CNS depressants, it's going to depress your respiration. So if ever a patient's respiration is under 12, please don't get that mad and call the provider and ask what he would like for you to proceed. It reverses, so this is Narcan, it reverses respiratory depression, it reverses sedation, hypotension associated with opiate agonists, and opioid partial agonists. So it works for both opioid agonists and opioid partial agonists, right? It's used to treat respiratory depression from excessive dose of opioid agonists or opioid partial agonists. And it's the drug of choice. It's also been approved to treat alcoholism. They're not effective in the central nervous system, not effective in CNS depression from tranquilizer or sedative hypnotics. So it's not effective for CNS depression medications like tranquilizers or sedative hypnotics. This is a reverse more for opioid overdose, okay? The most common adverse effects are rare, the most common adverse effects are rare: nausea, vomiting, chills, malaise, dysphoria, abdominal cramping, joint pain, mental depression, and apathy. So let's move on to slide 25. It's a question. You're welcome to answer that. If you want to know the answers, just let me know. Now I am going to move on to slide number 26. All right, keep in mind, y'all, we're still talking about pain management. These are medications that manage pain in the classes that they're in, right? Yay, so now we're going to move on to our prostaglandin inhibitors. Okay, and every time you see an inhibitor, that means it's inhibiting, stopping something, right? So these are prostaglandin inhibitors. The most common one you're going to come across is acetaminophen, that Tylenol. So what it does is it inhibits prostaglandins. It blocks the general generation of pain impulses in the peripheral tissue. It's used for discomfort associated with bacterial and viral infections, headache, and musculoskeletal pain. The most common adverse effect is gastric irritation, and the most serious adverse effect is hepatotoxicity. Now, here we go with that liver toxicity again. If your patient you're doing an assessment, y'all, and your patient has been taking Tylenol for a long, extended period of time, that is something the doctor needs to know, because we need to check their liver functions. It's toxic to the liver. So if a patient is telling you, oh, yeah, I've been taking Tylenol for the last year and a half, doctor probably needs to know that so that we can get a liver function test ordered, because it does cause liver toxicity, okay? The next group of those, Tylenol is what we call a prostaglandin inhibitor. Now I'm going to move on to slide 27, and we're going to talk about salicylates. And the most common one with this one is you're going to see is probably aspirin, okay? But the action of salicylates is they inhibit prostaglandin synthesis. 3 pharmacological effects. It's an analgesic, it's an antipyretic, and it's an anti-inflammatory. Aspirin has a unique property of inhibiting platelet aggregation and clotting. Basically what that's saying is that's why sometimes you'll see your heart and your stroke patients where they're taking an aspirin a day, because it does have a unique platelet, meaning it helps with the blood not clotting, okay? They are used for discomfort, pain, inflammation, or fever associated with bacterial and viral infection. Drug of choice is usually aspirin, the only main one I know. Then it's also used for headaches, muscle aches, rheumatoid arthritis. They're also used to reduce the risk of myocardial infarction, TIA, that's your transient ischemia attack, and stroke, right? Red Star. These are not recommended for children due to the risk of Reye syndrome. Red Star. These are not recommended for children because it's a risk of Reye syndrome, okay? If you haven't covered it up, look it up and find out what Reye syndrome is. Consciousness level is not diluted, so I mean they don't affect the person's consciousness. They're not confused or anything with their conscious ability. There's no memory loss. There's no mental sluggishness. no hallucinations, no feelings of euphoria, and there's no sedation like, people feel like, hey, okay. None of that with salicylates, okay? Please refer to table 19.3 on page 320 and 19.4 in the textbook on page 325. So page 320 and 325, okay? You'll get some more added information for these. Okay, so let's talk about the drugs that come in the salicylate family. And now moving on to slide number 28. So drugs, again, the most common one you're probably going to see is aspirin, or anything with aspirin or salicylate in it. And that's the medications listed here. Again, the biggest thing, adverse effect you're going to see, common adverse effect is GI irritation. If it's extreme, it's going to be a serious adverse effect, and you're going to have GI bleeding. And then if you have GI bleeding, then now they're going to have black and tarry stools because they're having blood in their stool. So this is why you got to get familiar and start connecting the dots on how these things affect the system, right? So so there's more serious adverse effects. So let's go back. So we're still talking about salicylates, which is primarily our aspirin or anything with salicylate byproduct in it, right? Serious adverse effect is GI area, common adverse effect. Only one, GI irritation. Then it becomes adverse, GI bleeding. With salicylism, the patient may have tinnitus or ringing in the ears, or impaired hearing, or dimming of the vision, sweating, fever, lethargy, dizziness, mental confusion, nausea, and vomiting. Use in children is not recommended due to the risk of Ray's syndrome. There is an increased risk of bleeding in older adults in the form of GI bleeding or hemorrhagic stroke. No antidote exists for aspirin toxicity, so there's nothing to reverse it, right? Discontinuing the drug is the only treatment, and the condition is reversible. So there's no Narcan for this. It's just stop taking the drug, and eventually the condition will reverse itself, okay? So biggest thing with salicylates is the effect that it has on the GI system. Also, because it's outside of the box, make sure you write these down for serious side effects that's on the side, the tinnitus and the impaired hearing and the vision involvement, because those are some of the non-common. Whenever you have your serious and your common and adverse effects, and you see a lot of those typicals and one across the board, the ones you may see them plugged in, but you're also going to more so see the ones that are not the one, that differentiate that med from another one, okay? I'm going to move on to slide number 29. That is a question. You're welcome to answer that. And now I'm going slide number 30, and that is the start of our NSAIDs, okay? You're going to almost hear them called by that, but you need to know what they are. They are non-steroidal anti-inflammatory drugs. So they don't have any steroids. They help decrease inflammation, and they're called NSAIDs, okay? So they're aspirin-like, but unrelated to salicylates, okay? They are prostaglandin inhibitors. They block this COX-1 and COX-2. There's varying degrees of analgesic, antipyretic, and anti-inflammatory activity. They are used to relieve pain and inflammation from rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, gout, dysmenorrhea, minor aches, and pains. None are superior to aspirin, but are preferred options for patients who do not tolerate aspirin. So, if we have a patient that does not do well with aspirin or salicylates, then our NSAIDs are the next go-to. That's what that's saying, okay? So, let's keep talking about these NSAIDs. I'm moving on to slide 31. So, Drugs you see in this class are listed under the drugs. Become familiar with them. The most common ones, again, you're going to see. There's some others, but Voltaren, and ibuprofen, Motrin, Advil, those are probably going to be the most common ones you see. So, but get familiar with some of the other names, because on the test, they're going to want to know if you know, so you need to know what the other drugs in this category are, okay? Excuse me. So the common adverse effects is gastric irritation, just like with aspirin, right? Constipation, it's a painkiller. They constipate, dizziness and drowsiness. Serious adverse effects, GI bleeding, just like salicylates, right? Hepatotoxicity, so we got liver stuff going on, right? Confusion, hives, pruritus, rash, facial swelling, nephrotoxicity. So now we're messing with the kidneys. Everything is metabolized to the kidneys and the liver, right? So, got to watch the liver and kidney function. In any blood discretion, they may also have blood discretions. This is all under serious adverse effects. For specific drugs, they're on they're in table 19.3, page 322. Now, there is an increased risk of potentially fatal cardiovascular emergencies like heart and stroke associated with long-term use. So, that's where patient education and teaching come in. You know, when you're doing your assessment, how long have you been taking this medication? Because they're saying there's an increased risk of potentially fatal cardiovascular emergencies like heart attack or stroke associated with long-term use. Drug interactions, Coumadin, phenytoin, valproic acid. Valproic acid is our seizure med. Lithium, that's our bipolar med. Aspirin, Lasix, that's one of our urinary meds. Blood pressure, diuretic, pull off that water. Know the drugs that interfere with NSAIDs. Warfarin, phenytoin, valproic acid, lithium, aspirin, and furosemide. That's Lasix, I'm pretty certain. So be familiar with those medications that interact with NSAIDs, okay? That was slide 31. Slide 32 is a question, and you are welcome to answer those. I will bring this material with me to class on Wednesday in case you want to go over your answers. Make sure you're on the right track. This concludes Chapter 19, Drugs Used for Pain Management. Hope you all have a wonderful weekend. Study, and then study some more. Again, this is all about you. Put into it what you want to get out of it. And on that note, you only the chapters we cover will be on the quiz. So that will be Chapter 16, 17, 18, and 19. Those are the only chapters that will be on this quiz on this Wednesday. And again, I wish you all the best and hope you all have a great weekend. Take care.